Question 1. Which of the following is the most appropriate initial intervention for a 3-year-old child who presents with bradycardia, heart rate 60 bpm following respiratory failure? A. Begin high-quality chest compressions immediately. B. Administer atropine intravenously. C. Administer epinephrine via endotracheal tube. D. Provide positive pressure ventilation EP. Answer: D. Provide positive pressure ventilation (PPV). Explanation: in pediatric patients, bradycardia due to respiratory failure is commonly caused by hypoxia. The first and most critical intervention is to provide effective positive pressure ventilation (PPV), which can help to reverse the hypoxia, thereby addressing the underlying cause of the bradycardia. According to PALS guidelines for bradycardia associated with respiratory PPV should be initiated immediately to restore oxygen levels. If bradycardia persists despite adequate ventilation, chest compressions and medications like epinephrine may be indicated. The administration of atropine is not recommended in the initial management of bradycardia in children, as it is rarely effective in reversing bradycardia caused by hypoxia. Option A is also incorrect, as chest compressions are not the first step unless ventilation fails to improve the condition. Option C is not the first-line treatment for bradycardia due to respiratory failure in this age group. Question 2. Mr. Davis is an emergency room nurse who is attending a 5-year-old child who was brought in with signs of shock. The child is tachycardic, hypotensive, and exhibits poor perfusion. The child's skin is cool and pale. After completing the primary survey, Mr. Davis decides that the most appropriate treatment for this patient would be to A. Begin fluid resuscitation with normal saline or lactated ringers. B. Administer dopamine as first-line inotropic agent. C. Initiate immediate intubation and mechanical ventilation. D. Administer epinephrine intravenously to reverse shock. Answer A. Begin fluid resuscitation with normal saline or lactated ringers. Explanation: the child in this scenario is presenting with signs of hypovolemic shock, which is often caused by severe dehydration, hemorrhage, or other fluid losses. According to PALS guidelines, the first-line treatment for hypovolemic shock in children is fluid resuscitation. Normal saline or lactated ringer solution is typically used to restore intravascular volume. Fluid boluses should be administered rapidly to improve circulation and perfusion. Option B is incorrect, because inotropic agents like dopamine are generally not the first-line treatment for hypovolemic shock. They may be considered if there is persistent hypotension after adequate fluid resuscitation. Option C is not the immediate step unless respiratory failure is also identified. Intubation should only be considered if the patient is not maintaining adequate oxygenation. Option D is also not the appropriate first-line therapy, as epinephrine is more commonly used in anaphylactic shock or as a medication in cases of cardiac arrest, but not as a primary treatment for hypovolemic shock. Question 3. A 6-month-old infant is brought to the emergency department by his parents. The infant has a history of severe respiratory distress due to viral bronchiolitis and is now presenting with increasing work of breathing, nasal flaring, and intermittent apnea. The medical team determines that the infant is in respiratory failure. What should be the next step in management? A. Begin high-flow oxygen therapy via nasal cannula. B. Administer a bronchodilator and corticosteroids. C. Intubate and begin positive pressure ventilation (PPV). D. Administer nebulized saline to loosen secretions. Answer: C. Intubate and begin positive pressure ventilation (PPV). Explanation: in this case, the infant is showing signs of severe respiratory failure, including increased work of breathing, nasal flaring, and intermittent apnea. The primary goal in managing respiratory failure in infants is to secure the airway and provide adequate ventilation. According to PALS guidelines, when a child is in respiratory failure and unable to maintain oxygen or ventilation despite non-invasive measures like high-flow oxygen, the next step is to intubate and initiate positive pressure ventilation (PPV). This will support the infant's respiratory system and prevent further deterioration. Option A. High-flow oxygen therapy via nasal cannula might be appropriate initially for less severe cases, but it is not sufficient in this scenario where respiratory failure is imminent. Option B. Administering bronchodilators and corticosteroids may help in certain respiratory conditions like asthma, but are not indicated for viral bronchiolitis-induced respiratory failure. Option D is not the correct approach in this case, as nebulized saline may provide some relief for upper airway congestion, but will not address the underlying respiratory failure in this infant. Question 4. A 4-year-old child is brought into the emergency department after A near-drowning incident. Upon arrival, the child is conscious but struggling to breathe and showing signs of moderate respiratory distress. The child is tachypneic, using accessory muscles for breathing, and has a pulse oximetry reading of 85%. The child's heart rate is 140 bpm and the blood pressure is 90/60 mmHg. Team suspects the child is experiencing acute respiratory failure due to aspiration of water. Which of the following is the most appropriate immediate management for this child? A. Administer oxygen via non-rebreather mask and closely monitor the child. B. Begin chest compressions and prepare for intubation. C. Provide 100% oxygen through bag valve mask, BVM, and prepare for intubation. D. Give intravenous fluid boluses to stabilize the blood pressure and wait for further evaluation. Answer: C. Provide 100% oxygen through a bag valve mask, BVM, and prepare for intubation. Explanation: in cases of near drowning with signs of acute respiratory failure, the priority is to maintain oxygenation and ventilation. Since the child is showing moderate respiratory distress and has a low oxygen saturation, 85%, providing 100% oxygen via a bag valve mask, BVM, is the intervention to ensure the child receives adequate oxygen. The decision to prepare for intubation is based on the potential for worsening respiratory failure and the need for definitive airway management. Option A provides oxygen via a non-rebreather mask but does not provide the level of support necessary for a child in respiratory distress with hypoxia. Option B, beginning chest compressions, is only appropriate if the child experiences cardiac arrest. Option D is inappropriate as fluid resuscitation alone will not address the immediate concern of respiratory failure and hypoxia. Question 5. A 2-year-old child is brought to the emergency department after ingesting a bottle of household bleach. The child is presenting with signs of nausea, vomiting, drooling, and significant respiratory distress. The child's heart rate is 125 bpm and the blood pressure is 90/55 mmHg. The child's respiratory rate is 40 breaths per minute with increased work of breathing and wheezing. Which of the following interventions should be performed next in managing this child's condition? A. Administer activated charcoal to absorb the bleach. B. Intubate the child and provide mechanical ventilation. C. Administer intravenous fluids to manage dehydration. D. Administer nebulized albuterol and corticosteroids. Answer: B. Intubate the child and provide mechanical ventilation. Explanation: ingestion of caustic substances like bleach can cause significant chemical burns to the upper respiratory tract and lungs, leading to respiratory distress. The child in this scenario is presenting with severe signs of respiratory distress, including increased work of breathing, wheezing, and tachypnea. In these cases, airway protection is crucial. Given the severity of the respiratory symptoms and potential airway compromise, the child should be intubated to secure the airway and provide mechanical ventilation. Option A is not appropriate because activated charcoal is not effective for caustic substances and may increase the risk of aspiration. Option C, administering intravenous fluids, is important in managing dehydration but does not address the immediate airway concerns. Option D may be useful later if there is evidence of bronchospasm but should not be prioritized before securing the airway. Question 6. Mr. Harris is a paramedic responding to a 7-year-old child who has been involved in a bicycle accident. The child is conscious but appears to have a significant injury to the left leg, which is angulated and showing signs of severe pain. The child is tachycardic and the blood pressure is 106 Hg. Mr. Harris suspects a fracture and must quickly decide on the next intervention. What is the most appropriate management for this child's injury? A. Administer analgesics and immobilize the leg before transport. B. Apply tourniquet above the fracture site to control bleeding. C. Begin fluid resuscitation to manage the child's blood pressure. D. Immediately attempt to reduce the fracture at the scene. Answer A. Administer analgesics and immobilize the leg before transport. Explanation: in the case of a suspected fracture, especially one that is angulated and associated with significant pain, the first priority is to provide adequate pain relief and prevent further injury. Administering analgesics and then properly immobilizing the leg are the best initial interventions. Immobilization of the leg will reduce movement, preventing further damage surrounding tissues and helping manage pain. Option B, applying a tourniquet is not indicated unless there is severe bleeding that cannot be controlled by direct pressure. Option C, fluid resuscitation, would be appropriate if the child exhibited signs of hypovolemic shock, but the child's blood pressure is still within reasonable range and is likely due to pain. Option D is incorrect because attempting to reduce the fracture at the scene is generally not advisable due to the potential for worsening the injury and further complicating pain management. Question 7. A 1-month-old infant is brought into the emergency department in respiratory distress. The infant is tachypneic, has nasal flaring, and appears to be working harder to breathe. The infant's parents report recent cold and cough but deny any fever. The medical team suspects bronchiolitis caused by viral infection. What is the first step in managing this patient? A. Administer bronchodilators and corticosteroids for wheezing. B. Begin oxygen therapy to maintain oxygen saturation above 90%. C. Initiate positive pressure ventilation (PPV) immediately. D. Start intravenous fluids and antibiotics to treat any potential secondary infection. Answer: B. Begin oxygen therapy to maintain oxygen saturation above 90%. Explanation: bronchiolitis is commonly caused by viral infections, particularly respiratory syncytial virus (RSV), and results in respiratory distress due to inflammation of the lower airways. The first and most critical step in managing an infant with suspected bronchiolitis is to ensure adequate oxygenation. The infant's oxygen saturation should be maintained above 90%, and supplemental oxygen via nasal cannula or non-rebreather mask is the initial intervention. Option A is not the first line of treatment, as bronchodilators and corticosteroids are generally not effective in viral bronchiolitis. Option C is premature unless the infant is in severe respiratory failure and unable to maintain oxygenation. Option D is incorrect because antibiotics are not indicated unless there is clear evidence of bacterial infection, which is not suggested by the symptoms in this case. Question 8. A 3-year-old child is brought into the emergency department after a motor vehicle accident. The child is conscious but has a significant mechanism of injury, and the medical team suspects a head injury. The child is showing signs of confusion and irritability, and there is a noticeable contusion on the forehead. What is the most appropriate next step in the management of this child's head injury? A. Perform rapid head CT scan to assess for intracranial injury. B. Administer mannitol to reduce intracranial pressure. C. Observe the child for 24 hours in the emergency department. D. Perform lumbar puncture to assess for possible meningitis. Answer A. Perform a rapid head CT scan to assess for intracranial injury. Explanation: given the significant mechanism of injury, signs of confusion and irritability, the child may have sustained a traumatic brain injury (TBI). In such cases, a head CT scan is the most appropriate next step to assess for intracranial injury, including bleeds, contusions, or skull fractures. A CAN can provide immediate information and guide management. Option B. Administering mannitol may be appropriate if there is confirmed increased IPE, but the first step is to diagnose the injury. Option C is not appropriate in the setting of potential brain injury, as the child may require urgent intervention. Option D. Performing a lumbar puncture is not indicated unless there is suspicion of meningitis, which is not supported by the clinical presentation. Question 9. A 6-month-old infant is found unresponsive at home. The infant is not breathing and no pulse can be detected. The mother reports that the infant has been having difficulty feeding and had a cold for the past few days. After calling for help and confirming the unresponsiveness, which of the following is the most appropriate action for the first responder to take? A. Begin chest compressions at a depth of 1/3 the anterior-posterior diameter of the chest. B. Administer 2 rescue breaths and then begin chest compressions. C. Start chest compressions and rescue breaths in a 30:2 ratio. D. Begin CPR with chest compressions only without rescue breaths. Answer B. Administer 2 rescue breaths and then begin chest compressions. Explanation: in cases of pediatric cardiac arrest, especially in infants, the first step is to provide rescue breaths to address possible hypoxia before beginning chest compressions. Infants often experience respiratory failure as the primary cause of cardiac arrest, so the focus should first be on oxygenating the infant. The initial 2 rescue breaths should be followed by chest compressions if the infant does not respond. The recommended ratio for infant CPR is 30:2 for single rescuers, but only after initial rescue breaths. Option A is incorrect because it skips the critical step of providing rescue breaths first. Option C is accurate for later stages of CPR but does not apply in the first few moments. Option D is incorrect because performing chest compressions alone does not address the most likely cause of the arrest in infants, respiratory failure. Question 10. A 4-year-old child is brought to the emergency department after ingesting an unknown quantity of over-the-counter acetaminophen. The parents report that the child was found with an open bottle of the medication, but they are unsure how much was consumed. The child appears well at the moment with no obvious symptoms, but the parents are concerned. What is the next best step in managing this case? A. Observe the child for 4-6 hours and provide supportive care. B. Administer activated charcoal to prevent further absorption. C. Obtain serum acetaminophen levels and initiate N-acetylcysteine (NAC) therapy if appropriate. D. Perform gastric lavage to remove the drug from the stomach. Answer. C. Obtain serum acetaminophen levels and initiate N-acetylcysteine (NAC) therapy if appropriate. Explanation. In cases of suspected acetaminophen ingestion, especially in children, it is important to obtain serum acetaminophen levels to assess the potential risk of toxicity. If the levels are above the threshold for toxicity, N-acetylcysteine (NAC) therapy should be initiated promptly to prevent liver damage. Option A is not appropriate, as acetaminophen ingestion can lead to serious toxicity even if no immediate symptoms are present. Option B. Administering activated charcoal may be considered within an hour of ingestion, but it is not the most important intervention for suspected acetaminophen toxicity. Option D. Gastric lavage is not recommended in cases of acetaminophen poisoning unless ingestion was very recent and the child is critically ill. Question 11. A 15-year-old girl presents to the emergency department with complaints of abdominal pain and vomiting. Her last menstrual period was 4 weeks ago. On examination, her abdomen is tender in the lower quadrant and there is guarding. The pelvic exam is positive for cervical motion tenderness. A urine pregnancy test is positive. What is the most likely diagnosis? A. Acute appendicitis. B. Ectopic pregnancy. C. Pelvic inflammatory disease (PID). D. Ovarian cyst rupture. Answer. B. Ectopic pregnancy. Explanation. This adolescent girl presents with abdominal pain, vomiting, and positive pregnancy test results, which strongly suggest an ectopic pregnancy. Cervical motion tenderness is a key sign of pelvic infection, but it is also seen in ectopic pregnancies. Early pregnancy loss, especially when it occurs outside the uterus, can present with these symptoms. Option A. Acute appendicitis may also present with lower abdominal pain, but the positive pregnancy test and cervical tenderness make ectopic pregnancy the more likely diagnosis. Option C. Pelvic inflammatory disease (PID) could cause similar symptoms, but the pregnancy test and the absence of other PID signs make this diagnosis less likely. Option D. Ovarian cyst rupture is possible, but the patient's positive pregnancy test and the presentation are more suggestive of ectopic pregnancy. Question 12. A 28-year-old woman with a history of asthma presents to the emergency department with worsening shortness of breath, wheezing, and cough. She reports increasing use of her rescue inhaler over the past few days and is now unable to speak in full sentences. On examination, she is tachypneic with an oxygen saturation of 88% on room air. The patient appears anxious and is using accessory muscles to breathe. What is the most appropriate next step in her management? A. Administer oral corticosteroids and schedule a follow-up appointment. B. Provide oxygen. Administer nebulized albuterol and consider intravenous corticosteroids. C. Reassure the patient and advise inhaler use as needed. D. Intubate the patient immediately for airway protection. Answer. B. Provide oxygen. Administer nebulized albuterol and consider intravenous corticosteroids. Explanation. This patient is presenting with an acute asthma exacerbation, likely due to insufficient control of her asthma. Given the signs of respiratory distress, including tachypnea, accessory muscle use, and low oxygen saturation, the most appropriate management includes providing supplemental oxygen, administering nebula albuterol, a bronchodilator, and considering intravenous corticosteroids to reduce inflammation and improve lung function. Option A may be appropriate for less severe cases, but this patient is in distress and requires more immediate treatment. Option C is inadequate because the patient needs active intervention due to the severity of the symptoms. Option D is not indicated unless the patient experiences respiratory failure or complete obstruction, which has not been demonstrated in this case. Question 13. A 65-year-old male with a history of hypertension and smoking presents to the emergency department with sudden onset chest pain radiating to his left arm. The pain started 30 minutes ago while he was shoveling snow. On examination, the patient is diaphoretic and appears anxious. His blood pressure is 106 to 9 mmHg, heart rate is 100 bpm, and oxygen saturation is 94% on room air. What is the most appropriate next step in management? A. Administer sublingual nitroglycerin and morphine in order and B. Order a chest x-ray to rule out pneumothorax. C. Perform a thyrocardiac workup, including a stress test. D. Administer aspirin and initiate intravenous heparin. Answer A. Administer sublingual nitroglycerin and morphine in order and explanation. This patient is presenting with signs and symptoms suggestive of acute myocardial infarction, including sudden onset chest pain, radiating pain, diaphoresis, and associated risk factors, hypertension, and smoking. The initial management of suspected MI includes administering sublingual nitroglycerin to relieve pain and reduce myocardial demand, morphine for pain control, and ordering an ECG to assess for some segment changes indicative of ischemia. Option B is not appropriate, as a chest x-ray is not useful in diagnosing MI. Option C is not correct because a stress test is performed in stable patients to evaluate for ischemic heart disease, not in acute settings. Option D is part of the standard management but should follow initial pain relief and diagnostic assessment, including an ECG. Question 14. A 22-year-old male presents with a sudden onset headache, nausea, and vomiting. He reports that the pain is severe and located behind his eyes, with associated blurry vision. The patient also mentions experiencing halos around lights and has a history of episodes of eye pain. On examination, his vision is reduced in the affected eye and his pupil is fixed and dilated, unreactive to light. What is the most likely diagnosis? A. Cluster headache. B. Acute angle closure glaucoma. C. Meningitis. D. Subarachnoid hemorrhage. Answer B. Acute angle closure glaucoma. Explanation. The patient's presentation of severe headache, nausea, vomiting, blurry vision, and a fixed, dilated pupil is highly suggestive of acute angle closure glaucoma. This condition occurs when there is a sudden rise in intraocular pressure leading to painful eye symptoms, blurred vision, and potentially irreversible vision loss if not treated urgently. The characteristic finding of a fixed and dilated pupil does not respond to light is a hallmark of this condition. Option A. Cluster headache is characterized by unilateral periorbital pain but does not cause visual disturbances or pupil changes. Option C. Meningitis would present with signs of systemic infection, fever, and neck stiffness, which are absent here. Option D. Subarachnoid hemorrhage presents with a thunderclap headache but the absence of focal neurological deficits and the patient's eye-related symptoms point to acute angle closure glaucoma. Question 15. A 34-year-old woman presents to the emergency department with a complaint of progressive weakness, difficulty swallowing, and double vision. She reports that these symptoms have gradually worsened over the past 2 weeks. On examination, she is unable to maintain upward gaze for more than a few seconds and has ptosis. Reflexes are normal. The rest of her neurological examination is otherwise unremarkable. What is the most likely diagnosis? A. Guillain-Barré syndrome. B. Myasthenia gravis. C. Multiple sclerosis. D. Amyotrophic lateral sclerosis. Answer B. Myasthenia gravis. Explanation. This patient's presentation of progressive weakness, difficulty swallowing, double vision, and ptosis, especially with normal reflexes, is highly suggestive of myasthenia gravis, an autoimmune disorder that affects the neuromuscular junction. The hallmark feature of this condition is weakness that worsens with sustained activity, fatigability, and improves with rest. Ptosis and difficulty with eye movements are findings. Option A. Guillain-Barré syndrome typically presents with ascending weakness and loss of reflexes, but is associated with sensory deficits and autonomic dysfunction, which are not present here. Option C. Multiple sclerosis often presents with visual disturbances, sensory changes, and limb weakness, which is not seen in this case. Option D. Amyotrophic lateral sclerosis usually presents with both upper and lower motor neuron signs and progressive muscle atrophy, which is not the case here. Question 16. A 55-year-old male with a history of diabetes mellitus, hypertension, and hyperlipidemia presents with sudden onset right-sided weakness and slurred speech. He reports the symptoms began approximately 2 hours ago while he was at work. On examination, he is unable to move his right arm and has a right-sided facial droop. His speech is slurred, but he is able to follow commands. What is the most appropriate next step in management? A. Administer thrombolytics immediately. B. Perform ischemia of the head to rule out hemorrhage. C. Start aspirin and wait for further symptoms. D. Order an MRI of the brain to evaluate for ischemia. Answer. B. Perform a EK of the head to rule out hemorrhage. Explanation. This patient is presenting with acute neurological deficits, suggesting a possible stroke. The first step in management is to perform a non-contrast CT scan of the head to rule out hemorrhage before administering thrombolytics. Thrombolytics can be used in ischemic stroke, but they are contraindicated in the presence of a hemorrhagic stroke. Option A is not correct at this stage because thrombolytics should not be given before confirming the diagnosis. Option C is inappropriate as immediate treatment is necessary for suspected stroke. Option D is not correct because MRI is not the first imaging choice in acute stroke management, especially when a hemorrhage must be excluded quicker. Question 17. A 40-year-old male presents with severe, sharp chest pain that started 1 hour ago while he was exercising. He reports the pain radiates to his left shoulder and is associated with shortness of breath. He has a history of hypertension but denies any previous heart problems. On examination, the patient is anxious with a heart rate of 110 bpm and blood pressure of 149 mmHg. NEC is ordered, and the results show some segment elevation of Roman tone in EVAF. What is the most likely diagnosis? A. Acute myocardial infarction. B. Aortic dissection. C. Pulmonary embolism. D. Gastroesophageal reflux disease. Answer A. Acute myocardial infarction. Explanation. This patient's presentation with sharp chest pain radiating to the left shoulder along with the ECG findings of segment elevation in the inferior omentum and strongly suggests an acute myocardial infarction. My presence with chest pain, often radiating to the left arm or shoulder, and segment elevation on the ECG, which is hallmark of ischemia or infarction. Option B, aortic dissection, can present with chest pain, but it is more likely to have ripping or tearing quality and may also involve blood pressure differences between the arms. Option C, pulmonary embolism, typically presents with pleuritic chest pain and dyspnea, but the absence of risk factors for P makes this less likely. Option D, gastroesophageal reflux disease GERD can cause chest pain, but the ECG findings and the associated risk factors make mine more likely. Question 18. A 70-year-old female with a history of osteoporosis presents with acute back pain after bending over to pick up a grocery bag. She denies any history of trauma but reports that the pain is sharp and localized to the lower back. On examination, she has tenderness over the thoracolumbar junction and a slight kyphosis. What is the most likely diagnosis? A. Spinal stenosis. B. Vertebral compression fracture. C. Lumbar strain. D. Degenerative disc disease. Answer. B. Vertebral compression fracture. Explanation. This elderly female with osteoporosis is at high risk for vertebral compression fractures, which can occur with minimal trauma such as bending or lifting. The sudden onset of localized back pain, tenderness over the thoracolumbar junction, and a history of osteoporosis are classic signs of a vertebral compression fracture. Option A. Spinal stenosis typically presents with pain that radiates down the legs and is relieved by sitting and is not usually associated with acute back pain after bending. Option C. Lumbar strain can cause back pain, but is less likely in a patient with osteoporosis and no history of significant trauma. Option D. Degenerative disc disease typically presents with chronic back pain and not acute sharp pain after a specific incident. Question 19. A 68-year-old male with a history of coronary artery disease CAD presents with shortness of breath, fatigue, and swelling of his legs for the past week. He denies chest pain but reports that he has been feeling more fatigued than usual. On examination, his blood pressure is 138 mmHg, heart rate is 92 bpm, and he has bilateral lower extremity edema. His lungs have crackles in the lower bases. Where's the most likely diagnosis? A. Congestive heart failure. B. Chronic obstructive pulmonary disease, COPD exacerbation. C. Pulmonary embolism. D. Kidney failure. Answer A. Congestive heart failure. Explanation. This patient's history of coronary artery disease cared, combined with shortness of breath, fatigue, lower extremity edema, and crackles on lung auscultation, points to congestive heart failure, CHF. CHF, the heart is unable to pump effectively, leading to fluid retention and symptoms like edema and shortness of breath. The patient's crackles suggest pulmonary edema, a common complication. CHF. Option B, COPT exacerbation, can cause shortness of breath but would typically not present with edema or crackles. Option C, pulmonary embolism, presents with sudden onset shortness of breath, pleuritic chest pain, and hypoxia, which are not seen in this patient. Option D, kidney failure, can cause edema but would not explain the patient's crackles or history of CAT. Question 20. A 55-year-old woman presents with a 3-month history of fatigue, weight gain, and cold intolerance. She also complains of constipation, dry skin, and thinning hair. On examination, her heart rate is 58 BPM, and she has a coarse, dry skin texture with a slightly enlarged thyroid gland. Blood tests reveal an elevated thyroid-stimulating hormone, TSH, and a low free thyroid sign. What is the most likely diagnosis? A, hypothyroidism. B, hypothyroidism. C, Hashimoto's thyroiditis. D, Graves' disease. Answer B, hypothyroidism. Explanation: the patient presents with classic signs and symptoms of hypothyroidism, including fatigue, weight gain, cold intolerance, constipation, dry skin, and thinning hair. A low free T and elevated TH levels are diagnostic of primary hypothyroidism. The elevated TH indicates that the pituitary is attempting to stimulate the thyroid, but the thyroid is not producing adequate amounts of thyroid hormone. Option A, hypothyroidism, would present with symptoms such as weight loss, heat intolerance, and tachycardia, which are absent here. Option C, Hashimoto's thyroiditis, is an autoimmune disease that causes hypothyroidism but is not the most specific answer given the lack of other autoimmune signs. Option D, Graves' disease, typically presents with hypothyroidism and symptoms of an overactive thyroid, not hypothyroidism. Question 21. A 45-year-old male presents to the emergency department with a complaint of a sudden severe headache described as the worst headache of his life. He is nauseous and has vomited twice since the pain began. His blood pressure is 107 to 100 mmHg, and on examination he is alert but in obvious distress. Neurological examination reveals no focal deficits. What is the most likely diagnosis? A, migraine. B, tension headache. C, subarachnoid hemorrhage. D, cluster headache. Answer C, subarachnoid hemorrhage. Explanation: the patient's description of the worst headache of his life, along with sudden onset, nausea, vomiting, and elevated blood pressure, is highly suggestive of a subarachnoid hemorrhage, a headache associated with size typically described as explosive or the worst the patient has ever experienced. Option A, migraine, can present with severe headaches, but it would be accompanied by a history of recurrent episodes and may include visual disturbances. Option B, tension headache, is usually characterized by a dull pressure-like pain and is not associated with sudden onset or vomiting. Option D, cluster headache, presents with unilateral periorbital pain, usually accompanied by autonomic symptoms like tearing or nasal congestion, which are not seen here. Question 22. A 22-year-old female presents with a complaint of irregular menstrual cycles for the past 6 months. She has noticed increased facial hair and acne. She also reports gaining weight, particularly around her abdomen. On examination, her blood pressure is 130/85 mmHg, and she has a hirsute appearance with acne on her face and upper back. What is the most likely diagnosis? A, polycystic ovary syndrome, PCOS. B, hypothyroidism. C, Cushing's syndrome. D, hyperprolactinemia. Answer A, polycystic ovary syndrome, PCOS. Explanation: this patient's symptoms, including irregular menstrual cycles, hirsutism, acne, and weight gain, are highly suggestive of polycystic ovary syndrome, PCOS, which is characterized by hormonal imbalance leading to excess androgens, male hormones. PCOS is the most common cause of irregular periods and signs of androgen excess, including hirsutism. Option B, hypothyroidism, can cause weight gain and menstrual irregularities, but would not explain the hirsutism or acne. Option C, Cushing's syndrome, can present with weight gain, but the distribution of fat is more typically central. And other symptoms like a moon face, purple striae, and easy bruising would also be present. Option D, hyperprolactinemia, can cause irregular periods, but it is not associated with hirsutism or acne. Question 23. A 60-year-old male with a history of smoking and hypertension presents with a 2-month history of chronic cough, hemoptysis, and weight loss. On examination, he is cachectic with clubbing of the fingers, chest X-ray shows a mass in the right upper lobe. With the most likely diagnosis: A. Chronic bronchitis, B. Tuberculosis, C. Lung cancer, D. Pneumonia. Answer: C. Lung cancer. Explanation: this patient's history of smoking, chronic cough, hemoptysis, weight loss, and a mass in the right upper lobe on chest X-ray strongly suggests lung cancer, particularly non-small cell lung cancer, SALSA, which is often associated with smoking. Option A. Chronic bronchitis is associated with a chronic productive cough but would not explain the hemoptysis, weight loss, or the mass seen on imaging. Option B. Tuberculosis can cause chronic cough and weight loss, but hemoptysis and the imaging findings are more suggestive of cancer. Option D. Pneumonia typically presents with acute symptoms like fever and chills and would not explain the chronic course or the mass on the X-ray. Question 24. A 45-year-old female presents with a history of diffuse joint pain, morning stiffness, and fatigue. She reports that the symptoms have been progressively worsening over the past 6 months. On examination, she has tenderness and swelling in the proximal interphalangeal joints of both hands, a rheumatoid factor and anti-cyclic citrullinated peptide (CP) antibodies are positive. What is the most likely diagnosis? A. Osteoarthritis, B. Rheumatoid arthritis, C. Systemic lupus erythematosus, D. Psoriatic arthritis. Answer: B. Rheumatoid arthritis. Explanation: this patient presents with symptoms typical of rheumatoid arthritis, including morning stiffness, joint pain, fatigue, and symmetric joint involvement. The presence of positive rheumatoid factor and CP antibodies further supports the diagnosis. Is an autoimmune disease that primarily affects the small joints, especially in the hands. Option A. Osteoarthritis typically presents with joint pain that worsens with activity and does not cause morning stiffness or positive autoimmune markers. Option C. Systemic lupus erythematosus, SLE, can cause joint pain, but would also present with systemic symptoms such as a characteristic butterfly-shaped rash and positive antinuclear antibodies. Option D. Psoriatic arthritis is often associated with psoriasis and can cause asymmetric joint involvement, which is not seen in this case. Question 25. A 35-year-old male presents with a 3-day history of fever, chills, and a sore throat. He reports difficulty swallowing, and his voice has become hoarse. On examination, his temperature is 102 degrees, and he has red, swollen tonsil with pus on one side. His uvula is deviated to the opposite side. What is the most likely diagnosis? A. Streptococcal pharyngitis, B. Peritonsillar abscess, C. Mononucleosis, D. Epiglottitis. Answer: B. Peritonsillar abscess. Explanation: this patient presents with fever, sore throat, difficulty swallowing, and a deviated uvula, which are classic signs of a peritonsillar abscess, quinsy. The pus on one tonsil, along with the fever and hoarseness, further supports this diagnosis. The uvular deviation is caused by the pressure from the abscess. Option A. Streptococcal pharyngitis can cause sore throat and fever, but would not cause a deviated uvula or pus localized to one tonsil. Option C. Mononucleosis can cause a sore throat and fever, but is typically associated with generalized lymphadenopathy and splenomegaly, which are not seen here. Question 26. A 52-year-old male with a history of type 2 diabetes mellitus and hypertension presents to the emergency department with severe, sharp chest pain that radiates to his back. He describes the pain as tearing in nature and states that it began suddenly. His blood pressure is 109 to 110 Hg in both arms. On examination, there's a significant difference in pulse strength between his right and left arms. What is the most likely diagnosis? A. Acute myocardial infarction, B. Aortic dissection, C. Pulmonary embolism, D. Pericarditis. Answer: B. Aortic dissection. Explanation: the patient's sudden severe tearing chest pain that radiates to the back along with significant hypertension and pulse asymmetry is highly suggestive of an aortic dissection. This condition occurs when there is a tear in the aortic wall, allowing blood to enter between the layers. Aortic dissection can lead to life-threatening complications such as rupture or organ ischemia. Acute myocardial infarction presents with crushing chest pain, but typically does not radiate to the back or cause pulse asymmetry. C. Pulmonary embolism presents with pleuritic chest pain, shortness of breath, and tachycardia, which are absent here. D. Pericarditis can cause sharp chest pain that worsens with lying down and improves with sitting up. but it does not cause hypertension or pulse discrepancies. Question 27. A 30-year-old female presents with complaints of excessive thirst, frequent urination, and unexplained weight loss over the past month. She also reports feeling extremely tired. Laboratory tests reveal a fasting blood glucose of 208 mgl and positive serum ketones. What is the most likely diagnosis? A. Type 1 diabetes mellitus. B. Type 2 diabetes mellitus. C. Diabetes insipidus. D. Hypothyroidism. Answer A. Type 1 diabetes mellitus. Explanation. The patient presents with classic symptoms of diabetes mellitus including polyuria, frequent urination, polydipsia, excessive thirst, weight loss, and fatigue. The presence of high fasting glucose and serum ketones strongly suggests type 1 diabetes mellitus (TDM), which results from autoimmune destruction of pancreatic beta cells leading to insulin deficiency. B-type. Diabetes mellitus typically presents in older or overweight individuals and does not commonly involve ketosis. C. Diabetes insipidus is caused by a deficiency of antidiuretic hormone at day and leads to excessive urination, but it does not involve high blood glucose or ketones. D. Hypothyroidism can cause weight loss and fatigue, but it does not cause high glucose or ketones. Question 28. A 42-year-old woman presents with progressive muscle weakness over the past few months. She has difficulty climbing stairs and combing her hair. On examination, she has proximal muscle weakness but no sensory deficits. A muscle biopsy shows inflammation and muscle fiber necrosis. What is the most likely diagnosis? A. Myasthenia gravis. B. Polymyositis. C. Guillain-Barré syndrome. D. Multiple sclerosis. Answer. B. Polymyositis. Explanation. This patient's proximal muscle weakness without sensory deficits and the presence of muscle inflammation on biopsy are classic findings of polymyositis, an inflammatory myopathy caused by autoimmune attack on muscle fibers. A. Myasthenia gravis presents with fatigable weakness that worsens with use and improves with rest, affecting facial and bulbar muscles. C. Guillain-Barré syndrome presents with ascending weakness and involves sensory deficits, unlike this case. D. Multiple sclerosis presents with neurological deficits including vision changes and sensory loss, but does not cause isolated muscle weakness. Question 29. A 65-year-old male presents with difficulty initiating urination, weak urinary stream, and nocturia. He denies any blood in the urine or pain with urination. Digital rectal exam reveals a symmetrically enlarged, firm prostate. What is the most likely diagnosis? A. Benign prostatic hyperplasia BH. B. Prostate cancer. C. Urinary tract infection UT. D. Bladder stones. Answer A. Benign prostatic hyperplasia BH. Explanation. This patient's urinary symptoms, difficulty initiating urination, weak stream, nocturia, and symmetrically enlarged prostate on exam are characteristic of benign prostatic hyperplasia BH, common condition in aging men due to non-cancerous prostate enlargement. B. Prostate cancer may present similarly, but it often involves nodular or asymmetric enlargement. Rectal exam. C. Urinary tract infection UT may cause urinary symptoms, but typically includes dysuria and fever. D. Bladder stones cause intermittent urinary obstruction but would not explain the prostate findings. Question 30. A 28-year-old female presents with complaints of widespread musculoskeletal pain, fatigue, and sleep disturbances. For the past 6 months, she has tenderness at multiple trigger points on examination, but no joint swelling or inflammation. Blood tests, including inflammatory markers, are normal. What is the most likely diagnosis? A. Rheumatoid arthritis. B. Fibromyalgia. C. Systemic lupus erythematosus. D. Osteoarthritis. Answer. B. Fibromyalgia. Explanation. Fibromyalgia is characterized by chronic widespread pain, fatigue, sleep disturbances, and tender trigger points, with normal blood tests and no inflammation on examination. It is a disorder of pain processing rather than an inflammatory or autoimmune disease. A. Rheumatoid arthritis presents with joint swelling, stiffness, and positive inflammatory markers. C. Systemic lupus erythematosus would show additional systemic symptoms like rash, kidney involvement, and positive autoantibodies. D. Osteoarthritis primarily affects specific joints and does not cause widespread pain or trigger points.